It's one and all. How are you? What you know? Can you guys hear me? Oh, good. Hey, thanks, guys. Hey, Devin, Gohar. Hey, Rachel. Thank you. Justin, how you doing? Steph, evening back at you. Yeah. Hey, Steven. I sent you an email. Did you see that? Hey, Ken. So, we got an interesting evening ahead of us. I know, but I thought of you and I just had to share. I'm glad you got it. Yeah, there's a bunch there. Maybe more than you need at this moment, but some good stuff for sure. Um, so, yeah, you're super welcome. So, how did acid base balance sit with you all? You feeling okie dokie about it? Making some gains? Good. Awesome. Wonderful, David. Yeah, still a work in progress, but it's going to give you some fundamentals that are truly going to help you uh, in so many ways along our journey together in the study of paramedicine. So, yeah, we're building foundational material, aren't we? We're going to be doing that tonight as well. This lecture could be boring as all get out, but oh no, no. I've got a tremendous amount of stuff uh, that we're going to go over is going to help you in a myriad of ways. You're going to need to do some deep thinking on some stuff. We're going to go over airway equipment for BLS. We're also going to look at endotracheal suctioning. I know we're putting the cart before the horse a little bit there, um, but that's all right. We're also going to look at the oxygen paradox. We're going to do a little side trip talking about CPAP and BiPAP, although this is kind of the overview lesson. When we get into pulmonology much later in the program, we'll do a big old deep dive into CPAP, BiPAP, such a critically important intervention. And so we'll be able to take it deeper at that point because you'll have a deeper knowledge bank. So we've got so much. And Justin, you're right. No such thing as a boring lecture here. At least that's my goal and objective, Justin. Whether or not I accomplish it might be another matter. So before we do launch on the material for tonight, which there is a lot, I always want to ask you, what do you got for me? What you got? Anything you need to address? Any comments? Any questions? Any housekeeping business? Anything at all? Matthew, I can see that you are typing. Dan, you need to shut your mic down. Mr. Manning, he did it. Thanks for catching it, Matthew. He wasn't blasting us yet. It was benign, but hey, more eyes on the problem is good for me. We're a team, you know. We got to work as a team. So, basic airway management. Here's a guy. He's bag valve masking a gentleman. Unprotected airway. Not sure if he's got an OPA in there or not. Can't quite see. It's probably a staged picture, so it's probably not, or at least not a real one. Um, True or false? EMS providers are absolutely great at bag valve masking. True or false? What are the biggest problems? Not having a good seal. That's one thing. What else? Oh, John. Oh, John. And Brandy. And David. And Andrew. Oh, my goodness. And Justin. So true. Why is it still such a big problem? We've tried to make such a big deal out of this. Why is it still a big problem? What do you think? What is your rationale? Also, making sure you got the patient in a good open airway position. I'm on board with that, Matthew and Devin. Yeah, if you're breathing too fast because you're adrenalized or catecholamines are coursing around through your bloodstream, um, you're going to overbag your patient, right? And have we now learned how we're really doing some? We've only learned some of the bad things that we do when we overbag. We'll be learning about more bad things that we do when we overbag. We've learned that if you overbag and alkalize the patient's blood, you actually prevent oxygen from releasing from hemoglobin. Hey, there's a problem, right? That's actually a big problem. Shifting that oxyhemoglobin dissociation curve to the left. Left is L for alkalosis. In cardiac arrest, there's so many bad things that happen when preventing blood from returning back to the heart by hyperpressurizing the chest. That means we're not perfusing the heart, the coronary arteries, the brain. Super bad things, right? Um, okay, so you know that, so you need to get get on board with how we compensate for that, right, Sophia? And how you can best find your hand position. So there are a myriad of bad things that happen from overbagging, and it's not just EMS. I certainly have seen it in the emergency departments as well. I'm sure that it happens in other areas of the hospital too, right? Um, Hyperfocus and chest rise and hyped up providers. Yeah, that's why many times the first pulse you should check is your own, right? The first pulse you should check is probably your pulse. Yeah. So we need to be thoughtful. I mean, this is what these lecture series is about, is to give you a lot of knowledge. I'm a strong believer that if you understand why you're doing what you're doing, you are much, excuse me, much more likely to make it so, right? If you understand the reasons, the rationale, the consequences of not doing it properly, you're much more likely to do it properly. So it is your job to be appropriate in terms of tidal volume and ventilatory rates for your patients. Every breath, right? Every breath. We're going to look at the tools of the trade. Is how we're going to start off this evening. And let's begin with supplemental oxygen. Certainly, there are plenty of patients that do require supplemental oxygen, and some that probably don't. That people think, well, I can give, what can I do? What can I do? Well, I could give them some oxygen, right? Oxygen is not always the answer. We're going to have a little discussion about the oxygen paradox tonight and how, for some patient populations, it actually can be harmful based on their condition and their underlying O2 saturations. Um, if we are just giving oxygen, we have um, the ability, we should be giving humidified oxygen. And people don't do that anymore. Uh, and guess what? There's real consequences to giving dry oxygen. It not only dries up the mucous membranes, can drive secretions in the airways to turn them into little rocks that are obstructants, but it can actually damage the tissues. Double down on that with kiddos, right? I've also shown you something here that isn't very prevalent in the pre-hospital setting, and that is the high flow nasal cannula. Um, how many of you have seen a high flow nasal cannula? It's a separate device. It's not just applying high flow to a standard cannula, right? Um, it is able to give much higher liter flows, mucho higher liter flows. Yeah, exactly, Dan. Um, and it must be warmed and it must be humidified. Okay. What about oxygen cylinders? Again, you should be experts on this. I'm not going to waste a lot of airtime on it, but there are a few choice comments that I will make. We know these things can become missiles. It's oxygen under pressure. We know oxygen supports combustion. Not a good look. And we know we need to have good equipment and test our equipment, make sure everything's working properly. This is a pressure regulator for a portable. What is the most common reason that you get a leak uh, on your O2 cylinder with these regulators? Bad O-ring, exactly. So we need to be able to troubleshoot, fix this problem. It's easy enough to fix. You should know that the regulator for medical oxygen, the PIN system, it will only fit a medical oxygen tank, not any other tank of any other gas, right? Probably worth mentioning on the way by. Our onboard flow meters, some of you may have multiples in the back of your ambulance, right? A little Christmas tree makes for a nice pressure fit. That can be unscrewed, and the wider opening tubing can be attached to the piece underneath the Christmas tree. Again, humidification for oxygen delivery. You can't give a nebulizer treatment off a humidified oxygen source. It's got to be off dry oxygen. You can't do CPAP or BiPAP off a humidified oxygen source, generally speaking. It needs to be dry. But if you're just giving passive oxygenation, please do think about humidification. It makes a big difference. Hey, I wanted to show you this because I think it is important to be able to figure out how much O's you got left. What is the most common size of tank that you're using as a portable? Yeah, your D's, right? So What is a quick and dirty way to figure out how much O's you have left in terms of how many minutes to deliver? And it's the duration of flow formula. So what is the formula? You have a conversion factor that is unique for each tank size. You multiply that times the remaining PSI, that's utilizable PSI. And then, well, actually, it's the entire PSI. And then you divide it by the number of liters per minute you're intending to use in your O2 delivery, right? So the thing that this probably is most useful for us, I mean, our big, M tanks, or I guess Andrew, they're using K tanks. Those, you can figure that out too. But probably the most useful is our portables, our E's. And what is the conversion factor? Well, it's in the bottom left. For an E tank, D tank, excuse-moi, it's 0.16. So let's say we want to know, I'm going to be using a non-repeater at 15 liters a minute. Somebody's got an open mic. Uh, Please take care of your open mic. Anybody see who it is? I don't like popping and hunting up while doing this thing. I have to turn them off. Oh, it is Robert. Robert, I'm muting your mic. Robert M. Robert M. You have an open mic. I just muted you. All right, where was I? So, D-tank, conversion factor 0.16. Now, I want to be using a non-rebreather at 15 liters a minute, and I've got 1,500 PSI left in my tank. So, what do? 0.16 times 1,500. Take that product and then divide it by your liter flow, your desired liter flow, and that gives you how many minutes left you have on that tank. So, in this case, with 1,500 PSI at 15 liters a minute on my D tank, I got 16 minutes left. That's probably good to know, because you can suck down some O's with CPAP, for instance, right? Good to know how much you got left on a tank. Now, we think about the passive delivery devices, and here we have nasal cannulas. They come in adult and pediatric sizes. With the standard use nasal cannula, in other words, we're using it as we've always been trained, just for passive oxygenation. It is more comfortable for many people. We would not exceed 6 liters per minute for standard use of the nasal cannula. But are there off-label uses or other types of uses uh, for the nasal cannula other than for patients who require a little bit of oxygen support, who are breathing adequately? Uh, okay, so Andrew is onto something yet, and that is pre-oxygenation for RSIs. Maybe using a nasal cannula at the highest liter flow off your device, whether it's 15, 20, 25, and then adding to that either a non-rebreather over it with the maximum liter flow, the patient being in an open airway position for pre-oxygenation prior to RSI or part of DSI, or instead of using the non-rebreather with the standard bag valve mask, can you apply the bag valve mask with good mask seal and a high liter flow and oxygenate the patient without ever squeezing the bag? Can you? Yes or no? It's important to know about your tools, right? The answer is yes. You can use it as a passive oxygenation device. And so using these devices on the highest flow setting, you can passively oxygenate someone prior to an intubation attempt. That being said, I'm going to play a couple of videos. Grab the first one. This is George Kovacs. This is actually a great video. Um, he is also going to be putting a PEEP valve. We should talk about PEEP valves for sure on the BVM. So he's going to have a nasal cannula on very high liter flow. He's going to have a BVM with a very high liter flow and a PEEP valve on the BVM. This is a cadaver. There's a chunk cut out of the side so you can see the lung tissue. Let's check this out.
So this is passive high flow oxygenation using a BVM here with an aggressive jaw thrust and an oral airway, 25 liters via BVM. Not much happening in the lung. It's collapsed and it really remains so. There are nasal prongs on, but there's no oxygen being administered at this point. Now here, what we're using is 25 liters both through the BVM, but also through nasal prongs with a jaw thrust, but no PEEP. If you look very closely, there's the occasional alveoli that you can see it's being recruited, but not much happening. So what we're going to do is add a PEEP valve and dial it up to 10. And so 25 liters via the BVM passively, 25 liters via nasal prongs, aggressive jaw thrust, and 10 of PEEP. Let's take a look and see what's happening. Pretty impressive, progressively more alveoli being recruited, and ultimately the lung gets completely expanded just by passively applying high flow oxygen through the BVM and nasal prongs with a good jaw thrust and 10 of PEEP. When you let go, it deflates, and apply it, it completely re-expands the lung. So again, let's just take a look. Expands and collapses. Now let's look and see what it would take to re-expand it actively. So just one partial breath re-expands that lung. Now I'm going to let go, lung's going to deflate, and I'll reapply the mask here. Again, do a one-handed jaw thrust, mask hold, and 2 small breaths. 1, 2. Really done with that single breath. That's all it takes.
So that's really impressive to see, isn't it? You've ever seen this video before? It's quite remarkable. So that was 25 on a cannula, 25 on the BVM. This patient got an OPA in. Of course, you got to get him in a good open airway position. And then putting that PEEP valve on, the exhalatory port of the BVM, and he's dialed in 10. That's 10 centimeters of water. What is PEEP, by the way? It stands for positive end expiratory pressure. But what is it actually doing? What does it provide? Near the end of exhalation, it creates a back pressure, if you will, that the end of exhalation is against, right? Pushing against. So it will keep the alveoli inflated. It can actually recruit collapsed or atelectated alveoli. BVM can be greatly enhanced with the use of a PEEP valve. And that should be on every ambulance, and it needs to be used appropriately, because inappropriately could damage the lungs. This one of our instructors, he's the instructor doing the videos you all have to watch on RSI, DSI, difficult airway lectures, Joel Pratt. And this is some pig lungs, and this is a quick little thing that he did. It is by far the most dramatic. I mean, what that video just showed us pretty dramatic too. Let me check this out.
We have bag valve ventilation without a PEEP valve.
So just to set this up, these are pig lungs, pig trachea. There is an endotracheal tube in that trachea, and he's bagging those lungs.
Now we're going to go ahead and put a PEEP valve on. You see how full those lungs remain. Now we're going to take the PEEP valve off and show you the residual pressure that you get from having that PEEP valve on, and the lungs deflate completely.
So that is so graphic, isn't it? I'm going to play that again.
Now we're going to go ahead and put a PEEP valve on. You see how full those lungs remain. Now we're going to take the PEEP valve off and show you the residual pressure that you get from having that PEEP valve on, and the lungs deflate completely.
That's amazing, isn't it? Such a very good visual on what PEEP does to keep the alveoli open and inflated. This is another piece. This is Scott Weingart. Maybe some of you know him for MCRIT. And he's doing a poor man's CPAP in the emergency department. But just showing some off-label use of BVM, PEEP valve, cannulas, and he's just also, well, I'll just let him do it.
Strong enough. the bank to the boogie, so the boogie to the rhythm of the boogie to beat. To the rhythm of the boogie to beat. I dare go like simple and plain as prominent basic Zulu arrangement, rockin' amazement, flocko, radiant from heaven to pavement. They phony as a face, look nothing to play with. Spend time hating it, but that ain't changing it. God give it to me, nobody is taking it. Therefore, moving on the basis, stimulus. Standing in the twilight, I'm watching them get it in the walls, trembling in the air, simmering. She moving like more than the ears, listening, won't now. Test to your equilibrium, sonic wave booming all over your intimate. Skin on skin, in, skin on skin again. Put it on, get it off, get on, get it in. Ladies and gentlemen, misters and mistresses, cause the upper edge and synonym. Here it is, Boogeyman. Huh. Simmer down, simmer down, simmer down now. Simmer down now.
Is a BVM right here, normal BVM, but with the addition of something that just changes the entire device to something far more useful, which is a PEEP valve. Now we'll have the PEEP valve set to 10 right now, and what you'll see is that when I breathe out, we're going to get a reading of 10. Now the problem with that is if the patient's tachypnic, then they'll always have around 10 when they're expiring. But if they're not, if they're breathing at a normal rate, then they're only going to be at that 10 when they're actually expiring, and most of the time they're not. Now what you could do to augment that is if you put them on a nasal cannula, at around 15, 10, now they're getting the continuous flow. And now it's not going to be quite 10. So now that changes this device to something that with the nasal cannula now could provide continuous positive airway pressure with devices you have. It's incredibly safe. There's no risk of barotrauma. If the patient pukes, you take the mask away. So from my perspective, this is the ultimate poor ED's way of providing CPAP to patients.
Pretty great, huh? That's young Scott Weingart from several years ago. So this begins to give us a window into off-label uses for these tools, right? Now, we will be having a discussion coming up, a session after next, on waveform capnography, and we will revisit this, but most of you are familiar with this device for patients spontaneously breathing. They make them for adults, they make them for pediatrics. Some of them only measure exhale CO2. Others also can provide oxygen, low flow. You can't use them at these really high flow settings like we've been talking about off label, but you use them up to, I think the manufacturers say up to 5 liters a minute or something. This one is set up to deliver supplemental and measure the exhale CO2. If they're intubated, there's another measuring device that goes between the tube and the BVM, right? That measures the end-tidal CO2. So this is for the spontaneously breathing patient. But certainly this is a tool that some of you already are setting up for your medics. You have some familiarity with. And so we will be expounding upon that, right? For spontaneously breathing patients, we can monitor their exhaled CO2 and also provide some supplemental oxygen depending on the setup that you have. Simple face masks, most of you are carrying those on the ambulance. They can give up to about 60% oxygen depending on how well the mask seals. You would never, ever, ever put less than 6 liters a minute of oxygen through a simple mask. Hopefully everybody is keenly aware of that, although I've been surprised in the last few years how many students didn't know that. Thought you could go lower than 6 liters a minute on a simple face mask. That is certainly not true because you're not going to flush enough gas through the mask to wash out the CO2, and then you would just have the patient rebreathing CO2, which is, of course, not the objective. We used to carry partial rebreathers in addition to non-rebreathers. I think this particular mask is less commonly found on an ambulance these days. There's really not much advantage over a simple face mask with this device. There is a reservoir bag. It looks very much like a non-rebreather, but it is not a non-rebreather. A non-rebreather has a one-way valve between the mask and the bag. This does not. So when the patient exhales, some of the exhale gas is going to be able to re-enter the bag, which will dilute the oxygen concentration in the reservoir bag, right? So quite honestly, you don't get much higher oxygenation percentages than you would with a simple face mask, which is why you probably aren't seeing these anymore. It's just essentially the same as a simple face mask is too. You can get up to about 60% of those with them. If we do need to give high flow oxygen to a patient who is adequately breathing, then the non-rebreather is our jam, right? And depending on how well the seal of the mask is, you can approach 100%. We talk about 100% with the non-rebreather, but we know in reality you may not get exactly that because there's going to be some leakage around. You have somebody that has an irregularly shaped face or has a beard, it's going to reduce seal and therefore could reduce the ultimate amount of concentration that they can get. You need to at least put 10 liters a minute, probably better to put 12 or 15 through this device. So never less than 10. More commonly, we go for 12 or 15. And the exhalatory ports on the mask have one-way valves on them, which helps maintain a higher level of O2 concentration within the mask. There's also a one-way valve between the mask and the bag, the reservoir bag, which prevents any exhale gas from re-entering the reservoir bag. So every time the patient inspires, they're pulling 100% gas out of the bag. And of course, you know that you've got to have that bag full, at least by 2/3, before you put it on the patient's face, or else it's like putting their head in a plastic bag. How many of you have ever seen Venturi masks? We used to carry these years ago. They have not that common these days. Rachel's seen them in the emergency department. Some of you have seen them. So what the heck's up with these? In a patient who is fragile, like a severe COPD patient, who you want to give very precise percentages of oxygen to, so that you don't over-oxygenate them because they may be on this for a period of time. We know those patients breathe on a hypoxic drive, and it is feasible that you could put them into respiratory arrest if you elevate their O's too high because the brainstem says, oh, I don't need to breathe, there's plenty of O's, because their brainstem is monitoring low O's as their drive to breathe instead of measuring high CO2 as their drive to breathe. So these have these different valves on them, Venturi valves, and with a particular liter flow, you can give precise amounts of oxygen, right? So you saw these on Saturday. All right. Not seen the mask, but I've seen the valves for patients with trachs. Ah, okay, Dan. So they're color-coded. They tell you how many liters to put through and the precise percentage you're going to get out. They work by the Venturi effect. As the gas moves through the device and into the mask, it creates a vacuum. So it sucks air in through those vents on the side, and it does so at a very standard amount, right? So it's the mixing by way of the Venturi effect of gas room air being pulled in through those vents, side vents, based on the which of the valves you have and the liter flow is how you get a precise amount. So just to say they exist. Now, rescue breathing. We don't do this as a matter of course in our profession. We have our BVMs that are our friends. If we are out and about on our own, maybe in your car, you've got a simple mask, right, that you can use. But should you know how to do rescue breathing mouth to mouth? And the answer is 100% yes, you should. You might not be doing it on patients at work, but what happens when someone you know collapses or your kid collapses? You're, of course, going to want to ventilate them immediately if it's needed, and you need to know how to do this, right? So that's why I am reviewing this at this point in time. Also now, if ventilations appear to be required based on dispatch information in an arrest, but you would have no problem doing it to a friend or to your kid, right? And that's why it's important. And there are occasions where if the individual is willing, they may be coached to do so by dispatch until EMS gets there. So let's review this, right? So it's 21% oxygen thereabouts in the room air. You only strip a small amount out. When you exhale, there's still about 17%. So you only strip 4 or 5% out. So in other words, there's plenty of oxygen in your exhalation. This is limited by the vital capacity of the rescuer. Of course, there's great potential for infectious disease spread. And you could, hyperinflate someone, give way too much gas. Um, no one cares for that, David, right? And that's why you don't blow like a damn hurricane. Uh, if it was someone that you knew that collapsed in front of you and you would do it, make sure you're not being a human hurricane. Anyway, over ventilation can cause lung hyperinflation and gastric distension. Same problems we can have with the BVM when improperly used, right? So how does one do it? Get them in an open airway position, pinch the nostrils, take a normal breath, seal over the mouth, and then exhale. We always deliver breaths over 1 second, whether it's with the BVM or this approach here, and then remove your mouth to give them time for passive exhalation, right? Uh, Ventilating through the nose. Keep the mouth closed. Keep them in an open airway position. Ventilate through the nose, and same deal. What about, and I'm sorry, I don't know why these images are screwed up, covering the writing on the slide. Don't know why that happened. But what about an infant? Okay. Keep them in open airway position, which is basically neutral or just a little back from neutral. Cover both the mouth and the nose. Again, to deliver the breaths over 1 second. The same thing we do with the BVM, right? Don't want to blast breaths in quickly. Give them over 1 second, 1,000, right? Until you just see the chest rise. And then, depending on the age of the infant, again, for infants, probably going to do it maybe 25 breaths a minute, right? 30 breaths a minute, depending on how young they are. Mouth to stoma is definitely where I draw the line. But what what do you have? How can you jury rig this with the BVM? Let's say their trach tube came out and you need to ventilate. We're going to lay it much later in the program. We'll talk about trach tubes and how to deal with them and stuff. PD, actually an infant mask, right? Little infant mask, you can get a seal and ventilate that way, right? Cover up the trach tube. Let's say the trach tube is fine, but their vent failed or whatever, right? So you can put a infant mask over and get a decent seal that way. If it is a patient who has the tracheostomy, you could occlude the trach hole and ventilate through the nose and mouth. The person you can't ventilate that way is a person who's had a laryngectomy. If they've had their larynx removed, then there's no connection between the nose and mouth and their airway anymore. So that would be an exercise in futility, trying to bag them through their nose and mouth. You have to ventilate through the stoma, right, in a laryngectomy patient. A lot of people carry these things with them. They work very well, right? For when you're off, not on shift. If you encounter something, maybe carry these in your car, right? Have a nice one-way valve. You can set up oxygen to it when people show up. It is actually a great device to ventilate through. Keep them in an open airway position here using both hands to seal the mask. You've got the one-way valve that deflects the exhalation away from you through a filtered port. Again, the biggest issue is delivering too many breaths or too large a tidal volume. Same with any delivery device. Right? Then we have our lovely BVMs. But the infant bag is probably not useful as even for full-term neonates or infants of any age. And this has been true for some time. Who is aware of the fact that the infant bags are not big enough, even for attending a full-term birth, if you needed to bag, that the infant bags are too little? Any of you knew that before I just mentioned it right now? And why is it true? Why do they make them? They're so cute and cunning. And the reason that it is in fact the case that they're too small for the job is twofold. First of all, if you were having to resuscitate the newly born, they didn't pick up, start breathing on their own, and bagging was what was indicated. The first few breaths are not just tidal volume breaths; they're inflating their lungs for the first time, and that infant bag may not have an adequate volume. Again, your objective is just to see visible chest rise. But the other thing is people squeeze these bags too hard and blast the gas in very quickly. Again, over 1 second, that's how long we should be delivering breaths as a general rule. And it's just almost impossible to do it with a infant bag. They blast in too quick, which of course is going to be spilling gas into the stomach, right? Yeah. So really, you're better off with a PD bag. But here's the thing, and this is always true. It all comes down to the provider. And we just started our discussion tonight about how people suck with BVM. So it doesn't matter the size of the bag. If your technique is terrible, you know, the right size bag isn't going to help you. This is a thinking person's endeavor, right? This is a thinking person's sport. You need to be looking for just visible chest rise. You need to be delivering an appropriate number of breaths per minute, right? Um, which by PAL standards now in pediatrics is every 2 to 3 seconds, which is 20 to 30 breaths a minute. So it's kind of sliding scale based on the age of the little kid. In adults, it is 10 breaths a minute, not 10 to 12, but 10. And again, those breaths should be delivered over 1 second. So you could use any size bag if you're using it properly and only delivering the amount of gas just to see chest rise. So you need to be paying attention to what you're doing. But the infant bags are not recommended even for neonates. Also not recommended in the field are bags that have a pop-off valve. And this is a photo I took up close and personal of a bag with a pop-off valve. You can see it says 40 centimeters of water. And we measure airway pressures in centimeters of water, by the way, rather than millimeters of mercury. So if you have a patient with poor lung compliance, again, what do we mean by lung compliance being poor? It's hard for the lungs to expand or distend, right? This could be somebody with that's developing a pneumothorax, that's getting close to tensioning. This could be a severe asthmatic or COPD that's got a lot of gas trapped in their lungs. Um, if it if the lungs don't have good compliance and it takes a little more pressure to get the gas in, then the gas, once it hits 40 centimeters of water, is going to blow out this exhaust valve and not go into the patient. There is an override on this pop-off valve here, but again, patients with poor lung compliance, it's just going to blast out this valve if it takes more than 40 centimeters of water to ventilate them, right? We're just going to be careful with that because you can damage lungs. But again, recommended no pop-off valves on the PDBVMs. Again, smaller bags are good for the peds. For little kids, PD bags. For a little older kid, use the adult bag, right? Use appropriate liter flows. Now, there's an older generation of pediatric bag that is called a fish mouth. And if you look at the image down below, I'll get my arrow. This thing right here. You have to squeeze the bag to get this valve to open and then deliver the gas. This is an old style or a unique bag. It's not the standard BVM you're going to see anymore. But if you have one of these that has the fish valve in it, or leaf flap, whatever you want to call it, you can't seal the patient's face and deliver passive oxygenation, because the only way the gas will be delivered in this sort of bag is by squeezing the bag. The new butterfly BVMs have those. Well, you could not use those for passive oxygenation, Andrew, if they've got the fish mouth. I don't know what a butterfly BVM is. I'll have to find that out. So that's a not good if you were just going to open the airway, seal the mask, and passively ventilate without squeezing the bag. Be no go here with this particular bag. Ventilators, I'm not even going to get into. They more and more are coming to the pre-hospital setting, but our discussion here is going to be limited, and these are very sophisticated, and I'm not getting into vent settings tonight. Advanced airway management generally offers nothing if the BLS airway management is not being properly managed. So BLS isn't just what we do before ALS. It may preclude the need for ALS, and it is critical that we're using our basic skills. And then if we need to expand out for ALS, we can, but we would never put ALS in front of BLS. Or if you aren't good at BLS, what's up with that, right? You need to be very good. This happens to be a team that's preparing to do a rapid sequence intubation on this patient. They're using a checklist, which is very appropriate. Make sure everything's being done. This is a team sport. You need to train for it. And that's what's going on in this image, right? Standard head tilt chin lift to open the airway. And again, we'll be placing an airway adjunct that's appropriate. if need be. But again, you can't just open it and then let go, right? You have to keep them in an open airway position alone. What if you suspect cervical injuries? Of course, then we would use the modified jaw thrust. And this is the best picture I've found. There's so many crappy pictures of modified jaw thrust. I see pictures with the thumbs up on the cheekbones. It's just ridiculous. What are your hands doing? Well, first of all, you're keeping them in a neutral inline position. Secondly, with your fingers, you're lifting up at the temporomandibular joint, lifting the angle of the jaw. You're lifting the mandible forward. And what is the job of the thumbs? It's not to park them on your cheekbone, the patient's cheekbones. You should be pushing down on the chin. So you're lifting up on the temporomandibular joint. You're pushing down on the chin or on the mandible there. That's rocking the mandible up and forward, pulling the tongue out of the airway. So this is the best image I've found for proper hand position for modified jaw thrust. What if you can't get an airway with a modified jaw thrust? What do you have to do? What do you have no recourse but to do? Head tilt chin lift, that's right. If you can't get an airway using this, you've got to resort back to head tilt chin lift, right? Suction devices, your onboard suction, your portable suctions. There's one thing that's really true about the portable suctions. They only work when you bring them to the patient. This piece of equipment gets left in the ambulance so many times, right? And that's unfortunate because there are plenty of patients that it may be the first thing we need to do for them. Well, that doesn't really work if you've left the device in the ambulance dirt. And what about these catheters that we can use? The tonsil tip or Yankauer catheter is the one you're seeing in the topmost image. Some of them have a little hole that you have to occlude in order to get suction. Others do not have a little hole that you have to occlude in order to get suction. The one in the middle is being held differently. Is that a standard Yankauer, or does anybody recognize what that device is? I'll just tell you, it is got a larger bore to it. It is the Ducanto catheter. It sucks bigger chunks, all right? The Ducanto catheter, and in conjunction with managing a soiled airway in a patient that needs to be intubated, this is the hand position I'm going to use for the Ducanto. And then on the bottom are the whistle tip catheters. These are soft catheters. They're sterilely packed. You can suction down the endotracheal tube. We're actually going to look at that this evening. I'm putting the cart before the horse, and we haven't done intubation discussion yet. We'll do that next time. But we are going to look at endotracheal suctioning tonight because we can fit it into our lecture time. And it can be used, to suction nose and mouth as well. But it is a soft catheter. So hopefully you know about the whistle tips down the bottom. Hopefully you're familiar with the Yankauers up top. The Ducanto catheters, I'm going to play a little bit on what's called the salad technique. I think the demo guy is being too rough in a way. Again, this is, putting the cart before the horse a bit. I'll play some more of this over the break. This is in the library to watch the whole thing if you want. That's Dr. Ducanto there. But someone's going to be using his salad technique here. And they will be using a video laryngoscope and a special mannequin that they can pump some goobers into the airway. So let's watch this part.
The use of the NASCO salad simulator. We're using the manual pump to fill the pharynx of the mannequin. I'll show this with the video laryngoscope. As we can see, it's filling up very nicely. And I'm going to demonstrate the salad technique now. I'll begin with the suction catheter in my right hand. I'm going to be using a product by Score. This is the Ducanto catheter. I'm going to grip the catheter upside down in preference to the usual manner in which these rigid suction catheters are held.
Let me pause for a second. Because he's going to be intubating as part of this salad technique, laryngoscopes are always held in the left hand. So everything else has to be available to the right hand. That's the suction catheter. That would be the endotracheal tube. So just wanted to put that out there before we continue.
Decontaminating the oral pharynx. And I'm going to utilize this rigid suction catheter to actually push the tongue down so I can more easily put the blade inside the mouth of the mannequin. I'm going to perform this under direct laryngoscopy, and you're going to follow along with video. I'm decontaminating the hypopharynx and leading with the tip of the suction catheter. I'm engaging the valecula and exposing the larynx. I'm just going to suction some secretions and simulate airway contaminant on the larynx. Now, I would like to leave this suction catheter in place during the intubation, but you're going to see here that the suction catheter is totally in the way of tube delivery, whether that be direct laryngoscopy or video laryngoscopy. This is the reason I would want to leave the catheter in place in the event of repeated soiling. So I'm going to move the suction catheter to the left of the laryngoscope blade and place it into the upper esophagus. So in the event of repeated soiling, the suction catheter can absorb the airway contaminant. I'm going to deliver my tracheal tube now. I'm going to do this under direct laryngoscopy. And before I ventilate, I'm going to run a flexible suction catheter down that tracheal tube.
He's using too much force on that.
Gently release my laryngoscope.
You should never let go of the endotracheal
Suction
tube
tracheal
either.
tube.
Beautiful.
Now I'm going to ventilate.
Okay, there you have it. Okay, moving on here. The standard equipment that we
So I'll replay that during the break, and again, the whole thing's in the library. But this is called the salad technique, all right? And it is a remarkably great approach to help when you're trying to manage a patient who has got a lot of vomitus or blood in the airway. It's a fabulous technique. So let me play some more of that over our break. So that's what you're seeing in the middle is the Ducanto, and it is, again, it's got a much larger bore. It sucks bigger chunks. Once the patient is intubated, you probably spilled air into the stomach, and that bubble of air is preventing the diaphragm from dropping down. There's a lot of hemodynamic reasons that we should decompress gas out of the stomach. And really, once a patient is intubated, and you will not see medics do this or providers do this as often as they should, and this includes during an arrest, it can really make a difference during arrest. You should go ahead and place a nasogastric tube. And decompress gas out of the stomach. Towards the end of the evening, I'm going to play a little video on putting an orogastric or nasogastric tube in. What you're seeing in the upper image is the Salem Sump NG tube. It's pretty standard. It's got a side vent on it. You'll get your hands on these equipment in the labs and get to practice with it. In an infant, instead of using the Salem Sump style NG tubes, you'll use a feeding tube, and that's the teeny tiny little tube that you're seeing down at the bottom, right? But the point is, the tube goes in the stomach. You temporarily hook up to very low flow suction and then seal it off. But pulling the gas out of the stomach like that could go a long way to improving the patient's condition, their hemodynamics, and in a cardiac arrest may improve your ability to successfully resuscitate them. So, NG or OG. NG, OG, same things, just route you're using. In a patient who is intubated, I'd probably go the orogastric route. It's easier rather than go through the nose. All right. NPAs, these things are great. We know they work if the patient still has a gag reflex, but we need some help to keep their airway patent. We need to put some water-based lubricant here on the tube, and it needs to be properly sized from the tip of the nose to the angle of the jaw or to the tragus of the ear. Too big or too small a tube does bad things, but it can be very well tolerated in a patient who still has a preserved gag reflex. So the tragus of the ear is actually this little nurdle of cartilage right there, all right? So that's one of the ways to measure from the tip of the nose, tragus of the ear, to get the right sized device. So make sure you're using water-based lubricant. The right area is slightly larger, so it might be the best place to start in a patient that doesn't have a deviated septum or whatever. And the bevel is designed to easily go and slide along the septum when you enter through the right nary. So in the second image up top, he's kind of pulled back on the tip of the nose, created the pig nose look, and then slowly advanced the NPA until it is properly seated. Again, proper size. This can be great. OPAs, again, need to be properly sized. Inappropriate size could obstruct the airway, and no gag reflex. This is a good rule of thumb. What reflex disappears at about the same time as the gag reflex? Does anybody know? And there will be exceptions to the rule here, but it's not a bad place to start. Andrew, looks like you're typing. I don't know what that is. The gag reflex is what I'm looking for. Okay, the gag reflex. So if you flick someone's eyelashes and they don't flinch, right? They probably do not have a gag reflex, right? So you flick their lashes, their eyelashes, and you don't get a response. They probably don't have a gag reflex either. Okay. So obviously we don't want to use this on someone with a gag or reflex. And if the patient is coming around and probably is now recovering their gag reflex, we need to remove this thing because it will gag them and it will make them vomit, right? So making sure we're properly sizing it, corner of the mouth to the angle of the jaw. Again, in adults, we can grab the tongue in the lower jaw in a person who's completely out of it. We don't stick our thumbs in the mouths of people who are going to chomp on us. But you could insert the OPA upside down, and as you advance it, rotate it into place. Would you ever do that in a pediatric patient? Yes or no? No, 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 no. You could damage the palatine structures there quite significantly. In a kiddo, you're going to, again, if they are completely out of it and they're not going to chomp on you, grab their tongue and lower jaw and stabilize, and then follow the natural curvature of the tongue. And the other thing is you can use a tongue depressor, as they've got here, to stabilize the tongue and follow the natural curvature. Pre-adolescent. Okay. All right. So I think we know advantages, complications, and hopefully you are all set on inserting these things. All right. So that's our opening salvo. Let's see what else. I want to talk with us a little bit about CPAP here. Again, as I mentioned at the beginning of the evening, we'll revisit CPAP in a much deeper way later on in the program in pulmonology. Some of you may be, that do have vents, may be using BiPAP pre-hospitally. And there is a FlowSafe device now, I forget right now what its name is, that allows you to create a BiPAP-like effect without a ventilator. Has anybody seen those things? Yakov, do you know the name? Because I'm blanking on the name of it right now. They're actually very cool. Yeah, I'm throwing spaghetti at the wall on this one for the moment. I think I might have grabbed can't remember. I might have grabbed a video on them. Let me see if I can find if I grabbed a video. Oh, I think it's the FlowSafe 2 bi-level. I think that's what it's called. Maybe I didn't bring that into our classroom, but let me grab that real quick. We can look at it. Yeah, there's a switch to switch it to BiPAP. Let me go grab that. So here we go. FlowSafe 2 bi-level CPAP.
Here are important instructions for applying and setting a bi-level CPAP pressure up 10 over 5 centimeters of water pressure on the FlowSafe 2 Plus.
All right, so 10 over 5. When you talk about BiPAP, there's a pressure setting for inspiration, which is going to be the higher pressure, and then a lower setting during the exhalatory phase, which would be the lower number. And so this is set for 10 during the inspiratory phase and 5 during the exhalatory phase.
Start by placing the device in CPAP mode. Then, connect the oxygen tubing to a gas source. Set the gas flow to 8 liters per minute. Now, apply the mask to the patient. Adjust the gas flow rate to achieve 5 centimeters of water pressure for CPAP. If the manometer does not register, check the mask seal for leaks and adjust the straps. Then, if there are no leaks, adjust the gas flow rate to 10 centimeters of water pressure for CPAP and place the device in bi-level mode. Finally, adjust the EPAP to 5 centimeters of water pressure and then use the manometer as a guide to adjust both the IPAP and EPAP. Here are some reminders for successful therapy. The device is intended for gap patients that have respiratory distress and are not requiring respiratory failure protocols. Nebulizer treatments can only be given in the CPAP mode. Do not over-tighten the mask straps. Patients should have effective spontaneous ventilation. Healthy people can reduce the pressure to zero during inhalation, giving a false impression that the IPAP is lower than the EPAP.
So this is an upgrade. It's actually a very cool device. Again, you can't give inline nebs unless it's in CPAP mode, but this is definitely an upgrade. It's poor man's BiPAP, right? So that's pretty cool, isn't it? So CPAP stands for continuous positive airway pressure. It's kind of like sticking your head out of a car window going 30 miles an hour down the road. It's blowing gas into your nose and mouth, whether you're inspiring or expiring, right? It depends on a tight seal of the mask. So the straps have to be tight. If there is a gap and a loss of seal, this will not work. This is an older Buzniak style device. They take higher amounts of oxygen to drive them. And what is underneath that? Well, there is a nasal cannula, which could be delivering oxygen, but I'm sure it is probably the end-tidal CO2 cannula. So that's a really good thing to have underneath the CPAP. So continuous positive airway pressure, it is a form of non-invasive pressure support ventilation. Non-invasive pressure support ventilation. Because the patient is exhaling against air being forced in, it increases their PEEP, which means it helps to maintain alveolar inflation. It can recruit alveoli that have collapsed. Yeah. And it can prolong the time for gas exchange, right? We don't use this for patients with minor distress. We use it for patients with significant distress, but still those that have adequate ventilatory effort. It certainly can prevent the need for intubation, which is fantastic. And in many places around the country, it is a BLS level skill. Probably most of you have been trained to use it. The patient population you're most likely at a BLS level going to use this on are the acute pulmonary edema patients. These patients have very wet lungs. Um, Many of them may have flashed abruptly into pulmonary edema. It is not uncommon. It happens in the middle of the night. Their left ventricle is not able to forward pump blood to the body. Remember, your left ventricle is the system pump. And what is happening is that you have a plumbing backup in the lungs, and that's causing fluids to shift out of the capillaries into the third space, and then finally into the alveoli. This is not an uncommon patient. Many of you may well have encountered this patient at this point in your career, maybe many times, because it is, again, not an uncommon patient. Um, and these patients classically are hypertensive, tachycardic, and certainly tachypnic because they're very oxygen hungry. They're drowning. And this is a patient population that can greatly benefit from CPAP or BiPAP. So in acute pulmonary edema or APE, what is it that CPAP does? It's delivering a constant positive pressure during inspiration and expiration. It's raising the inspiratory pressure above atmospheric pressure. In other words, it's making it easier to get the gas into the lungs. And by the way, in pulmonary edema, they may have, 5, 10, 15, 20, 20, 30, 35, 40, 50 times more work to move gas than someone who is just quietly breathing. Think about that. When we say work of breathing, we're not kidding. It may take up to 50 times more work to move gas. And in pulmonary edema, think of those lungs as being big wet sponges. It's really hard to move those things. All right. So it makes it easier to get the gas in. It's remarkable how much it can help with that. And that is raising inspiratory pressure above atmospheric. And then it's applying PEEP during exhalation. So this is the beauty, right? Also true with BiPAP. Now, some of you may be able to use it in COPD and asthma with inline nebulizers at the basic level. It depends on what your protocols are. In asthma, the bronchospasm is down in the smaller airways, and there can be a lot of air entrapped in areas of the lungs, so they get hyperinflated. Their tidal volumes get smaller and smaller as more air is trapped. This is also a very similar thing, but for a different pathologic reason in, say, an emphysema patient, right? But they can both get a lot of collapse in the small airways, atelectasis, and hyperinflation. So if they are a candidate with inline nebulized medications, you can drive those drugs deeper into the airways and reduce the work of breathing quite significantly in this patient population. So it can reduce the CO2 being too high. It certainly, in all these patients, makes it easier to get the gas in so it can rest the muscles of respiration. It can splint open those small airways. And in both the acute pulmonary edema as well as the asthma COPDers, it can increase their functional reserve capacity. Harken back to our respiratory A&P lecture, and we talked about functional reserve capacity as being the amount of gas that is always in the lungs that you couldn't exhale even if you wanted to, plus the expiratory reserve. And it's about 1 liter in an adult. So it increases the amount of gas that's available for gas exchange. It improves their FRCs. It recruits alveoli that are collapsed. It can also prevent alveoli that are trying to collapse from doing so. It can quite remarkably reduce the work of breathing. Again, it can drive those nebulized meds deeper into the lungs and can greatly reduce the need for intubation. There are a bunch of different devices out there on the market, and I'm not going to go through them. It's an earlier gen of FlowSafe. Here's Pulmodine. Bi-level. Again, we can approach BiPAP with the FlowSafe 2 device, so you don't need a vent to do it. But bi-level is, again, a lower pressure setting for exhalation, right? And the standard teaching for this is the patient needs to be awake, alert, and consenting, able to manage their secretions for it to be an appropriate tool. And we have to be able to get a good mask seal on them. I will expand upon that later on when you get more savvy. But at this point in our discussion, let's keep it simple. There could be exceptions to that rule. You're right there with them. If something is going wrong, you can get that mask off in a hurry. But I'm not going to go to that stuff right now. Let's keep it simple at the BLS level for you. So a little bit on CPAP, certainly more to say later on. And the next thing I want to talk about, and again, this is a little cart before the horse, but it is suctioning through the endotracheal tube. And I'm going to play a video. This is a nurse. And I'll tell you, nurses are so great about really using proper techniques, not contaminating equipment, doing things as they should be done. And this nurse does a great job. So for suctioning down the endotracheal tube. So I'm going to play that, and then we'll have a little discussion about endotracheal suctioning. This is about 7 minutes long.
We're going to be doing a demonstration right now on endotracheal suctioning. This is an invasive procedure. We need to make sure that we have a doctor's order for this procedure. Most times an endotracheal patient is in the ICU and you have standing orders available to you for intermittent suctioning if the patient condition warrants it. So before I do any kind of procedure, I want to make sure
I will say in the unit, they can have the whistle tip catheter that's enclosed in an outer housing, and it's all part of the system. This is just the standard separate whistle tip. But anyway, let's go for it.
Assess my patient. I'm going to use my stethoscope to go ahead and auscultate for his breath sounds. I'm always listening skin to scope. I'm hearing adventitious sounds. I could hear rales. I could hear rhonchi, hear coarse breath sounds. And what I'm looking to see if what I hear compares with what I might see on the monitor would be like a low O2 sat, increased heart rate, increased respiratory rate. I might see the patient is a little bit more anxious, a little bit more moving about, showing some agitation. Condition would probably warrant it to be suctioned, and my doctor's order authorizes me to do that. I'm going to go ahead and make sure I gather my equipment that I need. I need my suction catheter kit, and here comes a container for my saline. I have sterile saline available. It's a sterile procedure. I'll demonstrate sterile technique as I go through this. I also want to make sure I have an oxygen source available to me. Patient is on a ventilator right now. We do need to give supplemental oxygen when we go ahead and we ventilate our patient in between suctioning technique. I need to make sure that my vacuum source is available and working. I'm going to take and make sure that when I put pressure over the vacuum tube, it does not go above 120 degrees there, millimeters of mercury for pressure. And I have that ready, set to go. I'm going to go ahead now and get my equipment ready here. I have made sure that everything is appropriate sizing that I need, appropriate kit, and that nothing is expired on my equipment. I'm going to go ahead and wash my hands. and I'm going to get my equipment ready. Opening up any kind of packaging, making sure you open it up the way for you. This kit comes with a little cup for the saline. I'm going to open it up. Sterile technique. I'm not going to touch the inside. I'm going to go ahead and take my saline. I'm going to go ahead and pour, not touching the fluid box, to the box there. Get my saline ready. And now I can go ahead and open up my catheter kit here. Again, I'm going to do uncrimping of those edges so it doesn't pop back on me. I'm going to make sure I'm only touching that outer inch to support the sterility of the equipment that's inside here. These gloves inside are sterile. They are not labeled right or left, but I am going to glove my dominant hand first. I'm going to reach down and only touch that cuff part that's going to be touching my skin. And on here, I can go ahead and I can glove my dominant hand first. Again, touching only the part that's going to be touching my skin. Now with my dominant hand, I'm going to touch this underneath the cuff here and apply it to my non-dominant hand. Now sterile, I'll do a fit test. I am now going to touch the sterile catheter here. I'm going to go ahead and just loosely gather around my hand here to get a little bit more flexibility. This hand will now be sterile. This hand is going to become clean. I'm going to take my catheter here and attach it to my vacuum source. I'm going to attach the two connectors together. Again, this is still sterile. This is now clean. My hand can go over the top here. Left hand is now clean only. I'm going to test my vacuum source here. Make sure that the vacuum source is working appropriately. I'm ready to suction a patient, but before I do so, my assistant's going to give my patient some supplemental oxygen. They're going to hyper-oxygenate the patient, do not hyperventilate. She's going to give 100% O2. The oxygen source is on full flush. She's going to give the patient a couple of extra breaths. She's going to remove the patient from the source. And as I go down, I'm going to maintain sterile technique. I'm going to go straight down the ET tube without touching my hand to the tube until I hit resistance or the patient starts to cough. Patient starts to cough, hit resistance, I will pull up 1 centimeter to 2, and I will apply intermittent suction as I come up the tube, so I don't hit their internal mucosa. Sterile technique still. I'm going to clear my tubing, and I'm going to reassess my patient. I'm going to check my monitor here to see if the oxygen saturation has come up, if the heart rate has increased at all with that procedure, which is normal finding, that it's come down to its baseline and that no arrhythmias are present. If I have stimulated any type of arrhythmia, I would want to stop the procedure and get the patient to baseline. My oxygen source has come up a little bit. It's not at his normal saturation yet. His condition appears like it would warrant a second return. Again, a patient is going to be removed from the suctioning, or from the oxygen source. I'm going to go down again, sterile technique, not touching that tube to my hands. I hit resistance, patient starts to cough, I pull up 1 centimeter and apply intermittent suction as I pull that tubing out. Twisting and twirling as I come out. I'm going to go ahead and clear my tubing again. Kathleen is applying supplemental oxygen, and I'm going to again reassess my patient. I see that he appears to be breathing easier, less agitation. Looking at the monitor, his O2 sat has returned to baseline now. Heart rate has come back to a baseline level now, and Kathleen can go ahead and put a patient back on the ventilator source. Now I want to go ahead and assess my patient's oral mucosa to see if it would warrant any kind of sectioning of saliva and secretions inside. Again, same thing. Now it's a clean procedure. This oral is not a sterile cavity. Intermittent suction as I go around the oral mucosa here. Again, I'm going to clean my tubing before I end my procedure. I'm going to take and gather that catheter in my hand. I'm going to remove my vacuum source. You can go ahead and turn that off for me. And now I'm going to remove my gloves. My tubing is in my dominant hand. I'm going to head and touch dirty to dirty, so I'm not touching my skin. I'm going to remove the catheter inside of my glove. Now making a mitt inside my hand, I'm going to reach under, pull the gloves over, so that I'm not touching any kind of secretions that may contaminate myself. I'm going to put these down, I'm going to throw away my equipment, and I'm going to wash my hands. After I wash my hands, I want to reassess my patient again. I will auscultate for his lung sounds. I will see what his vital signs are, and then I will, of course, document my findings and what I have done.
So that was very well done. This is a sterile technique. Now, you're going to hear people say, oh, it's a clean technique, and I've actually got a bad verbiage on this thing. It is technically a sterile technique. You are introducing something down into the patient's airway. And the last thing in the world you want to do is introduce germs down into the airway and set them up for some nasty infection. Maybe you helped them today, but now they died from it several days later, right? Or a week later. You got some nasty pneumonia. You technically should have sterile gloves. But I'm going to say that the worst techniques I've ever seen in my life were done in a pre-hospital setting for endotracheal suctioning. Again, why are we doing it? Removing excess secretions. helping to maintain a patent airway, improve oxygenation, reducing the work of breathing, preventing any aspiration of materials down into the lungs, right? But it is not a benign procedure. It can damage the trachea, and anybody that tells you to quickly advance the whistle tip until you meet resistance um, actually is maybe not doing a good description, because that can rip the mucosa off of the carina, because that's where you're going to meet resistance, right? So when you hit the carina, if you hit that thing hard, you're using too much aggression. And that in that Ducanto video I showed you, that guy was using too much aggression, putting that whistle tip down through the tube. So you need to use a gentle technique. Um, because you can damage things. Suctioning only on the way out, we are definitely suctioning gas out if you're suctioning someone, so you can generate hypoxia. You can generate alterations in blood pressure. You can stimulate cardiac dysrhythmias. You can collapse alveoli. You can even precipitate a respiratory or cardiac arrest. This is not a benign procedure, right? You'll be practicing it in our labs, and really practice is the way to go. But it is not a benign procedure. So you can certainly induce nosocomial infections into the airways, and in a patient who is gacking or hacking in relationship to it, which the patient who is conscious and will do, it can increase intracranial pressure. So we don't really hyperventilate patients anymore. We do need to adequately pre-oxygenate them. Use our, really, it says aseptic, but it should be a sterile technique. You should have a hand that the only thing it touches is the tube that's going in, and that hand is your should be your sterile hand or your clean hand. Only suction on the way out, twirling the catheter as you remove it, and you really technically don't want to suction in there for more than 15 seconds, generally speaking, right? 10 seconds in a kid. If you had to go in for another attempt, you really need to re-oxygenate your patient. You really shouldn't do more than 3 attempts. So if you have an adult, and we'll get into endotracheal intubation next time, but for a 7.5 or 8 endotracheal tube, you want a whistle tip suction catheter that occupies about half of the internal diameter of the endotracheal tube, and that is for an adult a 16 French catheter. Whistle tips are measured in French sizes. You don't want to use a lot of high pressure on your suction unit because you can damage tissues, right? And again, intermittently suctioning only on the way out to minimize excessive airway pressures. So technically, it would be sterile gloves. If you only can get a clean glove on, then so be it. But the glove that holds the suction catheter and is directing it into the tube should not touch anything else. Okay. And then you've got the appropriate size whistle tip. Some of them have depth markings on them. Some of them do not. You can have your partner assist you in connecting it to the suction and setting up your suction for you, right? You obviously need mucous membrane protection, and so a mask or face shield, goggles. You need your bag hooked up to 100% nose. Patient needs to be on the monitor and on pulse ox, and you need your stethoscope. So if the patient needs suctioning, you're going to pre-oxygenate. We don't hyperventilate. I need to remove that term out of this slide deck. Pre-oxygenate your patient. Maintain sterility of your dominant hand. That's the one that's going to be advancing the tube into the endotracheal tube. The non-dominant hand would be doing anything else that you need to do. So introduce the catheter using your sterile hand. Only suction on the way out. Rotate the catheter during withdrawal to make sure that you're moving secretions. And then go back and, if you had to do it again, oxygenate, ventilate the patient. Again, we don't hyperventilate. And again, avoid repeated attempts if at all possible, because this is not a benign procedure. In kids, you should reduce that amount of time for suctioning down to 5 to 10 seconds max, using lower pressure settings on your suction unit, and carefully watching for dysrhythmias, especially bradycardia. So watch the monitor, watch your patient carefully, and never put any kind of lubricant. Of course, we only ever use water-based stuff anyway, but never use any lubricant on the catheter. Right? No, no, no. So gentle pressure when advancing the catheter through the tube. Don't bang it off the carina. You can damage that. Never suction on the way in, and only intermittently suction on the way out. So that's a little bit on endotracheal. suctioning. All right. So I say it is break time, but I'm going to get something up on the screen before our break. So, questions or comments on that stuff, folks? Again, this is something that's easier just to practice once you get in the lab, but I am going to repeat that people use horrible technique in the field. And again, there's nothing good about introducing infection into your patient through the endotracheal tube. It's actually a disaster. Hey, Riley, I see you're typing. How do you suction the eye gels without the side port? If you're using a device that has a purpose-made port in it, then you use the whistle tip tube size, or the one that's supplied that goes with the device. And you can't suction the airway with those things. That's meant to drop an NG tube, right? Or a G tube down that port. So that's what the port on the eye gels or the supraglottic airways are for. The King LTSDs, those things. That's a port to put a G tube in the stomach to decompress the stomach. So you can't area. Okay. Makes sense, Riley? And again, we were specifically looking at endotracheal suctioning just now, right? So, you have a few fancy ones that have an extra port for suctioning the tube. Okay. Well, I actually don't know those, but not all of them have it. The PD ones don't. Yeah, I haven't had my hands on those, Riley, so I can't speak personally about those. I'd have to look at the specs on the device. Good question, though, and thanks for letting me know that there is something like that that actually exists, because I was unaware. I learn things from you all the time. That's why I love it, teaching, because you guys teach me stuff too. So I think what I'm going to do here is, this is Dr. DeCanto. He is really a genius for airway management. I'll start it back at the beginning. I'm going to set our clock for 15 minutes. I'm just going to stop it at 15 minutes. You'll get some of his preliminary discussions and a view of that procedure again, the salad technique. And I'll see you back after a 15-minute break.
Thanks for inviting me, and thanks for coming, everyone. I want to present to you possibly the worst lecture to give before lunch. It's a talk on airway decontamination. I'm an anesthesiologist. My main career has been Milwaukee, Wisconsin for 20 years. I started training in Chicago and ended up in Milwaukee, and my wife always said we'd either end up in basically Wisconsin or Texas, based sort of on my personality. So that came to light. My disclosures, let me go back one slide. I am an inventor of a couple things that I'll talk about. I invented a mannequin that vomits. It's a salad mannequin. I also invented a suction catheter. There's a picture of it on the right from my friend Jim Horowitz in New York City. His kids were playing with the suction catheter and he found it on the toaster. I will give you links at the end of the talk here so that you can look at the various products and some of the open source information I provided. My goal here is not to sell you a product, it's to sell you an idea, because you can go home and after we do this here at this seminar, I'm hoping that you'll take this home and make it your own. The goals of this presentation, is this microphone working okay? Okay, it's fading in and out of me. Why is airway contamination important? I'm going to show you a paper. This is commonly known knowledge, but I'm going to show you the literature that shows that airway contamination is probably the major cause of failure in your first pass success attempt at airway management in emergency medicine, critical care, and parts of anesthesia involving severely contaminated airways. I'm going to talk a little bit about the new tools and skills available for managing contaminated airways, and thirdly, we're going to talk about methods to learn how to handle the problem. So we're going to talk about a simulation system. When we talk about airway algorithms, we've all, many of the previous lectures mentioned airway algorithms, but what I want to say about this is that there's really sort of two ways of looking at this. There's the bright side and the dark side, and I'm going to talk about the dark side. Everybody wants to talk about oxygenation and ventilation, but the biggest obstacle to getting there is making sure that you have an unobstructed path for both ventilation, oxygenation, and intubation. So here we are. We're at the bright side of the airway management coin. On the bottom of the slide, you're going to see the airway algorithms. We owe a big thanks to Nicholas Grimes and his partner down in Australia for the Vortex. These are an improvement in the cognitive thinking of how to handle thinking in emergency situations, but they're only focused on oxygenation, ventilation. They may actually cause you to encourage you to ventilate in the presence of contaminant. I'm going to simply say to you right now that decontamination is a poorly defined but very important step in airway management. As Rich was saying in the previous lecture, it negates your ability to ventilate by mask or supraglottic airway. It will negate your nasal oxygen, your apneic oxygenation, and it will negate all methods of airway endoscopy. And there's a quote from Rich himself. It is a major determinant in the failure of first pass success intubation attempts. And here is the slide that if you want a piece of literature that you may find useful, this is the one to take the photo of. This is from Sakels and Mosier at the University of Arizona in Tucson. They took 4 years prospectively, and every single intubation in their ICUs were done with video laryngoscopy, 906 consecutive patients. They used predominantly a MAC-shaped video laryngoscope, and they used the glide scope. The top 2 determinants of first attempt failure were presence of blood in the airway followed by airway edema. This was published in recently, March 2017, of the Annals of American Thoracic Society. Now, here's the next question. For those of you who work in the pre-hospital environment, this is no big news, but in a French pre-hospital study in 2013, all out-of-hospital cardiac arrest victims greater than 18 years of age were entered into this database, and they asked the clinical question, what is the frequency at which regurgitation occurs during out-of-hospital cardiac arrest management? And what they found out was that 25% of these victims regurgitated prior to the arrival of EMS, and 7% of them regurgitated during airway management, during laryngoscopy. So, let's talk a little bit about why I'm here today. I am sort of an inventor of many things, including a concept, and my wife thinks that this is a really dumb name, but I explained to her I couldn't call it beef. There's no way it'll line up. It's salad, okay? It's suction-assisted laryngoscopy with simultaneous airway decontamination. I'm going to show you with simulation and some videos how to actually let your suction catheter, a rigid suction catheter, mind you, do the work of opening the oropharynx, hypopharynx, simultaneously decontaminating the airway, giving you a better chance at first pass success for getting the laryngoscope in the mouth around the base of the tongue to expose the larynx. And then I'm going to show you a way how to continuously decontaminate the hypopharynx during tracheal tube delivery. The fundamental points are we're going to use the rigid suction catheter like a tongue depressor. We're going to use it to actually open the oropharynx. We're going to control the tongue. If you shoot down the midline, as Rich is suggesting, if you have a problem with the tongue, you can use the rigid suction catheter like a hockey stick to literally push the tongue to the other side of the blade. It's very simple. We'll do it in simulation so you understand. It also will decontaminate on an ongoing basis. It helps you avoid the mistakes in emergency, the most common mistakes in emergency airway management: poor tongue control, insertion of a laryngoscope in a grossly contaminated airway, and it also gives you a strategy for ongoing airway decontamination. So I'm going to ask my colleague here just to launch the introductory video. The use of the NASCO salad simulator. We're using the manual pump to fill the pharynx of the mannequin. I'll show this with the video laryngoscope. As we can see, it's filling up very nicely. And I'm going to demonstrate the salad technique now. I'll begin with the suction catheter in my right hand. I'm going to be using a product by Score. This is the Ducanto catheter. I'm going to grip the catheter upside down in preference to the usual manner in which these rigid suction catheters are held. Decontaminating the oropharynx. And I'm going to utilize this rigid suction catheter to actually push the tongue down so I can more easily put the blade inside the mouth of the mannequin. I'm going to perform this under direct laryngoscopy, and you're going to follow along with video. I'm decontaminating the hypopharynx and leading with the tip of the suction catheter. I'm engaging the vallecula and exposing the larynx. I'm just going to suction some secretions and simulate airway contaminant on the larynx. Now, I would like to leave this suction catheter in place during the intubation, but you're going to see here that the suction catheter is totally in the way of tube delivery, whether that be direct laryngoscopy or video laryngoscopy. This is the reason I would want to leave the catheter in place in the event of repeated soiling. So I'm going to move the suction catheter to the left of the laryngoscope blade and place it into the upper esophagus. So in the event of repeated soiling, the suction catheter can absorb the airway contaminant. I'm going to deliver my tracheal tube now. I'm going to do this under direct laryngoscopy. And before I ventilate, I'm going to run a flexible suction catheter down that tracheal tube. Gently release my laryngoscope. suction the trachea tube.
Beautiful.
And now I'm going to ventilate.
Okay, there you have it. Okay, moving on here. The standard equipment that we have available to us was invented actually over 110 years ago in New York City by Sidney Yankauer. He was an otolaryngologist at Mount Sinai Hospital. He intended this for intraoral surgery in a day and age when ether was the major anesthetic used in the United States. As we all know, cautery and ether don't mix, especially in the oral pharynx. So your technique of hemostasis is direct pressure as well as the use of obviously absorbable chromic gut suture. So the purpose of that suction catheter was to remove the bleeding phase of the bleeding. So you could locate the bleeder, put direct pressure, and then put a stitch through the mucosa and tie a knot. So that's what that's designed for. These catheters are designed to not pull the clot off of the bleeding surface. It's designed to simply evacuate the blood so you can identify the site of bleeding and stop the bleeding. What we have commercially available, at least this is in the United States, this is a product circa 1998. It's called the Big Yank. It's 16 American dollars approximately in the United States. I don't know if this has European distribution, but this is a larger bore suction catheter that has a removable tip in the event that you encounter solids. The suction tubing itself is not removable from the catheter, and it's large, and it goes to what's called the pore spout or pore cap of the suction container. This is something that you don't see it very much in the U.S., but this is a cool product. It's called the LS4 Lipsky Schultz Super Sucker, and this is intended for solids. It is so bulky, it's something that you would never carry outside of a hospital if indeed you would acquire this at all. And the concept here is to have a large bore sucker with a large bore suction tubing the size of a ventilator tubing going back to a suction container. We're going to look at the evolution of the rigid suction catheter now. So from 1907 down to 2016, we have the Yankauer, the High D, which is a product by Score, the company that makes the Ducanto suction catheter, the S3, which I've brought along with me. It essentially looks like a big frozen yogurt spoon, which is intended to help you debride the pharynx of solid matter. And then we have the Ducanto, which is essentially a hypercurved version of the High D, but I've removed the vent hole. The High D's been available since 1987. This is a company that started in Los Angeles, California. Its major customer base, of course, is in the United States. The Los Angeles County Fire Department uses their products quite often. And this has been mainly a pre-hospital product in the United States until recently. The recent innovation of taking that catheter and making it into that shape allows it to work with glide scopes, D-blades, King Visions, air tracks, etc. It's compatible with the hypercurve video laryngoscopes. It also works very well with direct laryngoscopy. We've also removed the vent hole to reduce that potential to produce error during use. Learning and practicing the simulation requires you to modify an airway training mannequin. I'm sure that many of you have very old mannequins, as you've been in this business long enough. And I'm going to say to you that what you can do is you can modify it to do what we're going to do with the simulation later this evening and what you just saw in the video. We're going to basically, what I'm going to suggest to you is that if you're able to actually build the knowledge base and abilities of your newest members of your group or your department from the ground up by teaching airway decontamination as an initial skill alongside the other skills, I believe that we can produce a more resilient clinician moving forward into the future, whether they be physicians or physician extenders. This is a couple photos from simulating thick liquid airway contaminants. On the upper left is the Orland Park, Illinois Fire Department. They're very much into this. On the bottom right is a recent seminar in Wisconsin. This is a friend of mine from Wisconsin. His name is Robert Barracks, and he has decided to rebuild his airway management teaching program for his fire department completely around airway decontamination and video laryngoscopy. I have international partners in this project. I have a few of them here today. On the bottom left is a lady from Hong Kong. That's Xing Ko. And on the right is Tim Leuenberg down at Kangaroo Island, Australia. And I've got Carmine Della Vella here, and he is seen here teaching the mountain rescue crew from Italy in this photograph here. I was pleased to know at SMAC last year that the Sydney HEMS decided to make this a standard method of training. So just to let you know that one of the premier HEMS organizations in the world has decided to bring this in as a standard method of teaching within their organization. Having my name on this doesn't really make it doesn't really give me a tremendous amount of pride. What gives me the pride is that I was able to pass this on to someone who saw the value in it and said, this is the way we should be doing things moving forward. That is the meaning to me. So here we are at SMAC in 2015 when I first introduced this simulator. The lady on the right is now an attending in South Africa, and I don't remember the name of the guy on the left. But is this really an effective tool for teaching airway decontamination skills? I did do one study on this using what's called a learning perception study, in which we gave pre-test and post-test questionnaires to the individuals who went through the simulation. And what I was able to show was that there was a demonstrable improvement from, one level, from, say, 3 to 4 following the simulation, that they were confident in their ability to manage the airway of a vomiting hemorrhaging patient. I have a 4-minute video to show you next. It's going to be worth watching because I'm going to say something that I just learned recently, and that the upgrade that this technique can bring to basic life support may be equal or greater than the upgrade to
advanced life support. So let's go ahead and roll this video. So the question we're going to.
Hey, we're back. So, Riley, I looked over the break, and I couldn't find anything other than the gastric channel for eye gels. So if you've got something fancier than that, you can tell me what it is. I'd be happy to look it up, but I came up empty on that. I tried. So anyway, it was a bit on with Dr. Ducanto, who again is an airway genius. And most of all the videos I play in class are also in the library. Anytime you want to go back and watch something again. Okay. So our next topic is the oxygen paradox. And I tried to set you up for thinking about this when we did our pathophys lecture, part 1, and we were looking at ATP production and aerobic metabolism, and we got down to the electron transport chain. And I said, hey, while we're down here, let's take a side trip on the patient populations that if you over-oxygenate them, you can cause some damage, and specifically populations of patients who are vulnerable to reperfusion injuries. Do you guys remember the types of patients I specifically mentioned that are vulnerable for reperfusion injury? MIs, good, very good. Was there any others that I mentioned? Post-arrest, so once you get ROSC, that's right, Andrew. And there was one more patient, strokes. You got it. You got it. So I promised you that we'd do a little more on that, and I couldn't think of a better time or place than when we're talking about basic airway management, which is certainly where we bring oxygen to the table, right? So I'm going to take you back over the blackboard here in a minute, and we're going to do a little thinking about how is it that if you flood the MI patient or the post-arrest patient or the stroke patient with insane amounts of oxygen, how is it that that can cause bad things to happen? And what's up with the O's? So let's get some thinking done, and then we'll go to the blackboard and do a little more thinking about it. But there is a true paradox about oxygen. In the patient population in general that can be damaged with oxygen itself are ICU patients. I mean, they do everything in the world to not keep them on 100% O's for long periods of time, because any patient over a long period of time, 100% oxygen will damage the lung tissue. How many of you knew that? We're not even talking about these reperfusion injuries now. We're just talking about long-term exposure to high flow O's. So any patient, a healthy patient, you put them on 100% oxygen and leave them there for a few days, you will have direct damage to the lung tissue, right? So all of this is part of what can be referred to as the oxygen paradox, right? The oxygen paradox. Of course, we want to specifically target reperfusion injuries. Let's do a little initial thinking about this. So we know oxygen is essential for life. That's right. Anything, right, Rachel? Anything. Even apple pie. So, so it is such an interesting phenomenon that the very thing that we require, that too much of it is bad, right? Oxygen is certainly essential for life. At the same time, it is a proven toxin causing cellular injury and or death. How do we age? Aging is oxidation. Basically, we rust. That's part of aging. And the Tin Man, he was definitely oxidizing, wasn't he? He needed some lube. But here's a good example. Take an apple, cut it in half, leave it exposed to air, and you can actually see the process of oxidation taking place. And avocados also very quick to oxidize once they've been cut open, right? So oxygen is essential for humans and all true creatures that require anaerobic respiration or anaerobic metabolism, right? And we use it to make our ATP, but it is actually a very toxic gas. Okay. It supports combustion too. That's not good. And for long term, it can actually cause a lot of damage at high concentrations. So this slide, damn it, I need to fix this. Sorry, I'm cursing. Let me get my drawing tool up here. Let me get my tool up. All right. So that was true in 2010. So I guess I need to revise this. Here we are in the 2025 changes, which is, it was also true in 2020. They didn't really change this too much, and from there is now going to be different for certain patients, right? Now, in general, we think of anything better than 94 is good, but in our patients with MIs and post-arrest, these are not numbers we're going to use anymore, right? And they keep tweaking on these a little bit just to make us buy a new book, right? American Heart. So we're going to talk about the numbers. But here we are again. First of all, we had some fuel we need to break down into glucose. Cell undergoes glycolysis. We know that's anaerobic. But if there is plenty of oxygen, we can move on into the Krebs cycle and then on down to oxidative phosphorylation. This is the part of ATP production that requires oxygen and produces a heck of a lot more ATPs for the buck, right? This is where the good work gets done. But what happens when things go awry? And a good example would be in a patient who we get back from cardiac arrest. We pull them back from the jaws of death, right? Get pulses back. We're trying to stabilize them. Or a patient who's having an MI. These vulnerable patients we talked about, that are vulnerable for these reperfusion injuries. How is it that things can go wrong? And it's because you could get these secondary injury patterns, all right? So with that said, I'm going to take us over to the blackboard. And I've taken the liberty to draw a few things over here for us to get us started. So what I have here is the electron transport chain. That's what I've got going on here, right? And this is a many-step process that in the end spits out a lot of ATPs, right? The waste product is water, okay? But at each of these steps, electrons are moving across the membrane, and it creates these reactive oxygen species. And normally they only last for a very short period of time. And there are a number of them. We can just refer to them as ROS, reactive oxygen species. And there are several of them. A perfectly good example is the superoxide molecule, which is oxygen bound to itself, but it's got an extra electron, right? And these things are hot like fire. They're hot, 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 hot. There are other examples of ROS as reactive oxygen species. We also have reactive nitrogen species that can also cause problems, but we're not going to talk about those right now. We're sticking to the oxygen-based ones. In a happy, healthy system, our body is using reduction and oxidation to do all kinds of miracles that are life. Life is in many ways a redox phenomenon. But normally, in a happy, healthy system, these reactive oxygen species that we can just generally call free radicals and again, they're short-lived. We could also just refer to them as oxidants, right? In a happy, healthy system, they are balanced by antioxidants. Okay. What are some major antioxidants? Vitamin C is a major antioxidant. Vitamin E is a major antioxidant. And the most important intracellular and intramitochondrial antioxidant is something called glutathione. Critically important, glutathione. So in a system that is working well, the oxidants, the antioxidants will balance each other out. Life is good, right? But we're talking about particular populations of people that are vulnerable. So let's pick on the patient, and let's say this is the post-arrest patient, right? And or the MI patient, either one. The blood supply is in large part being cut off to critical organs, and the ones I'm especially interested in are the heart in the MI patient, the brain and the heart in the post-arrest patient. So if we have just given a crap ton of oxygen when it's not necessary to these patients, that's when the bad things happen, right? So let's pick on the MI patient just for the ease of it. And so we have the patient, and most of you know that it is a blockage in the coronary artery. That is the problem, right? And the blood supply has been cut off to some part of the heart muscle in that patient. So if we just flooded them with oxygen, it's not going to get to the part of the heart muscle where the blockage is in the coronary artery that's supplying that muscle. When is there going to be a problem? And it's when that blockage has been removed. Maybe you got that patient to the cardiac cath lab and they went in and mechanically removed the clot, opened up the artery, and now you've got all this arterial blood that's flooding back in here, right? It wasn't there before because there was a blockade, okay? And you just had that patient on a non-rebreather because that's what your basic EMT instructor told you to do, which was a bad thing and hasn't been true for a long time. But it's amazing how much bad information is still out there. And so now you just literally flooded this sick tissue with oxygen. So let's kind of look at the state of affairs of the sick tissue, right? It had to switch over to anaerobic metabolism. There was a lot of acids building up, all these hydrogen ions, right? The tissue is insulted and inflamed. We know inflammation causes the mast cells to degranulate, release substances like histamine and other things. That can cause capillary leakage. It can just ramp up inflammation locally, right? But if you flood these sick cells with high levels of oxygen, you're going to produce a lot of these free radicals, right? This isn't happy, healthy tissue that's balanced out by the antioxidants. And these free radicals do something called lipid peroxidation. Lipid peroxidation. They will literally destroy cell membranes, these reactive oxygen species that are out of control here. They will destroy nuclear membranes. They will destroy mitochondrial membranes. These are called reperfusion injuries. And these injuries can be more profound than the initial injury that, in this case, the heart muscle suffered, right? If that patient is having an MI, 911 gets called promptly. We get there. We do a 12 lead. We recognize the MI. We begin supportive care. We get them to the cath lab promptly. They open up that artery and reperfuse that muscle. We're saving muscle right and left, aren't we? That's all good. But we've got this system where if we've loaded this patient down unnecessarily with oxygen, that can cause more problems and more tissue insult than the original MI. Or in the Ross patient, think about this happening in the brain, okay? So this is horrible. If we get down to the cell membrane level, and this is outside the cell, this is inside the cell. Well, this is inside the cell. Well, I guess this is supposed to be inside the way I drew it. The cell can't produce enough ATP anymore, number one, right? Because it had to flip over to anaerobic metabolism, which is going to mean the sodium-potassium pump can't keep the sodium pumped out and the potassium pumped back in. So we got a problem. So now sodium starts getting in, and it can get in mass, right? Because we can't keep the inside in and the outside out because we don't have enough energy to do it. We know that when sodium comes, wherever sodium goes, that water follows. So we're going to get a lot of sodium and water entering the cell. This can cause the cell to swell up. It can actually kill the cell, right? You also are going to start losing potassium out of the cells because we can't control that. And the cell will eventually make a deal with the devil. And it's like, yeah, I absolutely cannot take any more water and sodium getting in here. We must stop this. If you'll stop with the sodium, I'll let some calcium come in, right? Well, a small amount of calcium in the cell may be necessary, but when you start allowing calcium to have free reign, calcium will also destroy the nuclear membranes, the mitochondrial membranes. So it just destroys the tissues, right? So we're getting this secondary insults at the cellular level, right? All right, I'm trying to get my thing to slide back over. So we've got this inflammatory thing that's set up, right? And as these mast cells degranulate, and one of the things that they're doing is they're sending out cytokines or chemokine signals saying, help, help, help. I need some help over here. Things are pretty bad. And we start having the first responder white blood cells show up. Maybe recall neutrophils, our first responders. And they're quick to arrive on the scene. And they start showing up because this is becoming a disaster zone here. These neutrophils start showing up in mass, right? So all of these neutrophils show up, like a whole bunch of them. And guess what happens? They create a traffic jam. And now this blood vessel is occluded again for a totally different reason, because you have neutrophils that are streaming in here and plugging up this vessel again. Well, apparently that's a bad idea, right? We are now have this neutrophil plug, and we've cut off the blood supply to the tissue again. That was completely unhelpful, right? The capillaries will leak, and the cells begin to die. So cells that survive the initial insult will succumb to free radical damage, okay? And can be killed. Sometimes the secondary injuries are worse than the primary insult. Think about that, right? Think about that. So that's a visual for you to think about what happens with these reperfusion injuries. There's a whole bunch of bad things that go down, aren't there? Not a good look. Not a good look. So in hypoxic brain injury, post-cardiac arrest, MIs, these secondary injuries can be quite profound. Okay? And why are they happening? Because we just went hog wild and gave high amounts of oxygen that created this problem, because it was not handleable by those compromised tissues. And instead, it just spewed free radicals out like crazy, right? So in cardiac arrest, these secondary brain injuries can be quite profound, right? Again, the outer part of the brain, the cerebral cortex, is the smart part of the brain, supposedly, right? and it is the most vulnerable part to hypoxic and reperfusion injuries. And it can cause all kinds of bad things. It can cause swelling of the brain, bleeding, secondary bleeding can happen, clots can form, and these are secondary insults. So we need to make sure that we're minimizing these things, right? In post-cardiac arrest syndrome, we want to save the brain. Here are some bad things that can happen, right? The patient can become comatose, have seizures, have long-term cognitive dysfunction. They may even have strokes in the brain or the spinal cord. They may develop secondary Parkinson's or Parkinsonianisms. And they can even just have frank brain death, right? So subsequent death from brain injury after ROSC, not a big surprise you're going to see higher amounts of it pre-hospitally, because it may be a while before someone calls us, what has been the downtime on that patient, right? So it's not like in hospital where they might recognize a patient code and maybe, right, much more quickly and do something about it. So hours to days after return to spontaneous circulation, there are multiple mechanisms, including the free radical damage, that can destroy the brain tissue. The brain that's ailing will start firing, electrically firing and firing and firing and firing. And it basically creates a toxic soup. That's called excitotoxicity. Again, can't keep the calcium where calcium needs to be. And then there are other cascades of things that can just be destructive in addition to the free radical formation. Okay. Here is the superoxide free radical, right? It is an oxygen molecule with an extra electron. But there are other oxygen-based reactive oxygen species. Peroxide, superoxide, hydroxyl ion, hydroxyl radical. There's a bunch of them. And these free radicals are hot, 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 and they can fry the place, right? Years ago, we started using a procedure called therapeutic hypothermia. And any post-arrest patient that remained comatose, once we got them in, and in fact, years ago, we were starting to cool these patients pre-hospitally. We're not really doing that anymore. We were using ice cold saline and getting their temp down. What was the point of cooling? And again, it still is done in hospital as one technique post-arrest, and it was to reduce the metabolic demands of the brain. If you can reduce the metabolic demands, you can reduce a lot of these injuries, these secondary injuries, right? Reduction in metabolic demands, reduction in the amount of oxygen required, and metabolic rates. You can reduce. When the first therapeutic hypothermia protocols came out, I remember so clearly folks I knew in the ICU were just absolutely aghast because patients that they would have previously said were brain dead, right, were coming back neurologically intact and walking out. This was a huge, huge thing. And over the years, this technique of cooling them or maybe not cooling them, just keeping them so that they don't get fever, that they at least maintain normothermia. Some systems in the units, that's how they do it. They won't actually drop the core temp. They'll just prevent fever from happening and keep them normothermic. Others may put them into a mild to moderate state of hypothermia and leave them sometimes for 48 hours now. Depends on which hospital. And are there specific ways to cool the patients? No, there's a bunch of different devices out there, everything from the Arctic Sun to endovascular cooling devices, different approaches, right? Cooling mats. But they were actually seeing that this was salvaging people's brains, right? And some of those people were surviving this with good brain function. So this is amazing, right? Just amazing. They've even tried cooling. Well, a lot of what we do is based on recommendations. And, when we first started this, and there were some very proactive docs that were pushing for this, we were like dumping a couple of liters of ice cold saline in them on the way to the hospital. And some systems, if they were using paralytics, would sedate and paralyze so that they couldn't shiver and make heat. Some systems were dropping into esophageal thermometers to monitor core temps. But apparently that may not be the best approach. And so can I completely answer your question? No. Are there systems in this country that may still be cooling on the way in? Probably not using ice cold saline anymore. And cooling on the way in means nothing if they don't continue the procedure once you get to the hospital, right? So it's all part of a team effort. They've also looked at cooling patients post-MI for the same purpose, to salvage heart muscle that was salvageable, but ended up being damaged from these secondary insults, these free radical injuries, right? So they've even explored those sorts of things. So reperfusion ischemia of the heart, triggered by reactive oxygen species, inflammatory response, cellular swelling, intercellular calcium overload. Also, the muscles of the heart will contract down and not really release properly. The vasodilatory mechanisms get messed up. There's damage to the mitochondria. The neutrophils show up and cause traffic jam and plug up the vessel again, and then cells start committing suicide, right? So we'll dive into the actual numbers later on, but let's stick for MIs. Let's keep it simple tonight, and I'll expand on this on another night with 20, 25 numbers. If you have an MI patient and their O2 sat is at least blank, we will not give oxygen. What is that number? No, I don't see it. All right, Devin has it. Devin has the right answer. If they are satting at least 90%, we will not give them oxygen. Okay? And the reason for it is reperfusion injuries. It used to be 94. It never was 92 for MIs. And that's why I was cursing on the beginning slide, because it said 94. It's 90 now for MIs. Okay? And I'll keep it simple tonight for that. How many of you have seen this done pre-hospitally? Or how many of you are still blasting these MI patients with those? Because now you understand why it's a bad idea, right? Now you know why. I think the 2025 numbers for post-arrest in adults are 92 to 98 percent is where you want to keep them. But I'll talk about that more in detail when we talk about care of Ross patients. But let's stick MI for the moment. So if they're sitting at 90, no O's, right? So that's something that's important, just as important as giving oxygen to your hypoxic patient that needs it. We're never going to deprive someone with oxygen if they require it, but we also don't want to give it just for fun, right? And we have to be careful about certain populations because of these reperfusion injuries. Questions on that, folks? And I can maybe give you the best answer, Andrew, about why we stopped. Largely due to American Heart Association. No. Again, during the cardiac arrest, we're using 100% oxygen, right? But once we get them back, we'll talk more in detail about ranges later on for 2025 numbers. And there's always exceptional patients, right? But we'd like to at least keep them at 92 to 98. Your local protocols are to oxygenate dyspneic or hypoxic or signs of heart failure. That's fine. But that's different than someone having an MI, right? If you've got a patient who's hypoxic, we definitely want to treat it. right? But in the context of an MI, where they don't have pulmonary edema, right? Straight up MI, no other complications. We don't want to give VOs because of these reperfusion injuries. So I thought this was a good night to consider this sort of thing, right? Because we want to be good clinicians. That's our central goal and objectives, is to get smart so we can be smart as to how we take care of these folks, right? And do right by them and not just, deal with old dogma that has somehow, lingered much longer than it ever should and should be long gone. And so that is tonight. Now we're going to tackle advanced airway next time, and that will include looking at endotracheal intubation and looking at the supraglottic airways. Okay. Now the following, and I'll mention this again next time. The following class, well, hang on a second. We're going to have you will be watching the Managing the Difficult Airway lecture series, and I'm looking at it right now. I'm not going to share my screen. You can look at it as well as I can. And that's Joel Pratt, and it's a series of lectures. He has one on supraglottic airways. I don't care if you watch that one. We're going to be discussing the supraglottic airways as part of our advanced airway discussion, which will be next time, talking about intubation. Very exciting, folks. So that's what I got for you tonight. I hope it was good for you, and we'll see you back next time. Get smarter as we go. So one more question: is this the 90 number for STEMI? Yeah, for MIs. For MIs, it's different for ROSC. I'll give you the ROSC numbers later, Andrew. Sorry, I didn't see your question. All right. Have a great rest of the evening, and you all are super welcome, as always. Awesome, Stephen. I want to know what your grandpa's name is. I'm just curious. You're welcome, everybody. Have a great night. Take care, folks. Be safe out there. Yay, Justin. Glad to hear it.